Any coordinator from the OT? Are we? Can we know about the next case? I mean,
Next,
are we,
yeah,
are we
next
doing
is
the vitrectomy?
next. Dr. Gaurav is performing. It's a phakic IOL.
Right, Dr. Gaurav Luthra, welcome. Welcome to the live surgery. Dr. Gaurav?
Yes,
Hi, good evening.
am I audible?
Yeah. Hi, this is Abhishek, and we've got Dr.
Hi, Abhishek.
Vardhaman here.
Yes.
And
Who all are there? I'm sorry, I didn't. Is that
Dr.
Abhishek?
Vardhaman,
Hi, Dr. Gaurav. This is Vardhaman.
Hi, Vardhaman. How are you?
I
am good.
Okay, so we have a slight delay. I mean, we'll probably take another 2 or 3 minutes to start off because my patient is still being draped.
Absolutely.
And in the meantime, I can quickly tell you about the patient. I have the file here.
Absolutely,
I'll
Dr. Gaurav.
okay.
Yes.
I hope you had a good trip, Vardhaman.
Absolutely. Very well. Thank you so much. Looking forward to your surgery.
So, we are going to do an ICL. This is the Biotech ICL, which is new on the block, and I've used a few of these in the past few weeks.
Absolutely.
And it is nice. It's got a central hole just like the Centraflow ICL,
Yes.
and does not require any PIs. It's a hydrophilic lens, and its handling is very easy. So my patient has a myopia of about 11.75 in the left eye with some astigmatism, and she improves to 6.9. She has anisometropia, so the fellow eye is about 5.5 sphere with 1 diopter of cylinder.
Wow.
And while we have ICLs available for both eyes, we are planning to do only the left eye today,
Sure.
which has the higher correction. And I'm going to go on the steep meridian. She has astigmatism in the left eye at about 170, 165, 170 degrees.
Okay. What is the amount of astigmatism? Dr.
So
Gaurav?
the astigmatism is actually on the higher side. She has about 2 diopters of astigmatism.
Okay.
And problem is that we are not going to be able to use the toric ICL here. We are going to use the spherical ICL alone.
All right.
And so we are planning to go on the steep meridian, and this is the left eye which I am operating.
Yes.
So the thing about this ICL that I've learned over the last few ICLs that I've used is that I've realized that the loading and this thing is much easier than what we have been used to over the last few years. The ICL loading used to be the most tricky part,
Yes.
which I've realized is much easier with the new system, and then the injector system is very familiar to what we've been used to using with the IOL. So it works out quite easy for most cataract surgeons also to use. And okay, I think we'll manage. So my patient is a little bit apprehensive. We are just managing. It's not gone in. Wait. So, beta eyes खोल के रखो. Yeah. Actually, we had to drape her again because somehow the drapes became unsterile.
So what is the maximum correction that can be done with this new ICL, Dr. Gaurav?
So the range of, see, what I have done till now is about 15 or 16. That was my highest. But I can quickly ask the company people that what is the range that they have. So minus 20, 23, and their toric is to be launched very soon.
Sure.
Can we just move this out of the way? So they are currently have only a spherical ICL. Can you give me the foot pedal for the machine and the microscope? We'll be using the Zeiss microscope. Yeah. I'm going to use the Zeiss microscope. Superior बैठ जाते हैं अभी, because अभी सारा. So because everything is set up for a superior thing here, I'm going to sit superiorly only, and I'm not going, since it's the left eye, I'll be using the. इसको stool को थोड़ा सा आगे कर सकते हैं. So.
Yeah. On the other side, you can see that Dr. Mathur has very well finished the implantation of the new acryl preloaded IOL.
कौन सा
Absolutely
part
wonderfully
sterile है?
done surgery, Dr. Mathur. Congratulations.
You want to do it?
In spite of all the.
No, we just changed the IOL.
Great.
Yes.
Thank you.
yes,
We
yes.
changed the IOL.
Yeah, absolutely. We thought so.
Now it's over.
All right. Okay. Thank you so much, Dr. Mathur. Now
My
we'll
pleasure, my
move to the next case with Dr. Gaurav.
Yeah, sure.
Yeah.
Can you put something to dilate her, please? Tropicacil plus. Some to dilate. Which part of this is sterile, the microscope?
Blue.
Okay. So let's see. I'm just setting up. So in the meantime, Dr. Maipal has reached here. He's all set for his surgery, and then we have after my surgery, there's a vitreoretinal surgery lined up.
Okay. Great. So as I can see, Dr. Gaurav, the pupil doesn't seem to be very well dilated. So you're
We want
planning-
Tropicacil plus first.
Right.
Actually, ना TM plus or something. Parakin भी डाल दीजिए और वो T plus भी डाल दीजिए, please. Pupil constrict हो गया.
So in certain cases, Dr. Gaurav, quickly is the V4C model that we are using in ICL. sometimes you still do see some amount of increase in intraocular pressure.
So
but
my
have you seen
patients,
such scenarios with this new phakic IOL?
So आप लाइट को देखते रहिएगा रिलैक्स करके, ठीक है? My patient's pupil is actually reacting, if you can see that.
Yes.
So you know, I'm going to be having a bit of a.
Yeah, it's actually
You
reacting
can
to the
notice,
microscope.
it's actually constricting to light. So let's see. If they have intracameral this thing set up, I can probably use that. But आप लाइट को देखते रहना. So is the ICL and everything ready? I don't know. Oh yeah, बस इसको आप रखो.
So you're planning to use intracameral adrenaline?
Yeah, I'm
Dr. Gaurav,
hoping
for
to
this?
use that. Let's see if we can get it.
Okay.
So,
Sure. So any pearls, for example?
so we've had
if
an excellent day today in the surgery actually, and everybody has been on their toes, and I think we've stretched the OT staff to the limit. But
so
can
any
you ask
pearls?
somebody to prepare intracameral adrenaline?
yeah.
Huh?
Dr. Gaurav, any
Okay,
quick
okay,
pearls for our
Okay,
audience
so
here?
with this ICL, you know,
Yeah.
the handling is much easier.
Yeah.
I mean, as compared to the typical ICL that we've all been used to using. So
Right.
the loading is much easier, and the injection, and even the manipulation inside is much easier. So you don't need the PIs, and I've had no IOP spikes post-op in the few lenses that I've used.
Right.
And the only thing is, I've been waiting for them to come up with the toric version, which is likely to come out very soon. And the material is very friendly actually. So they have a hydrophilic material.
Acrylic.
Yeah, but पहले तो incision कराएंगे ना. All right. हाँ जी. अब नाक से अभी हटा नहीं पाएंगे क्योंकि ना फिर आपको नाक की हवा आँख में जाएगी. आप बस थोड़ी देर रिलैक्स करो प्लीज. आप लाइट में देखते रहो, आप इधर उधर नहीं देखना, ठीक है? So I'm planning to make a nasal incision somewhere at 165 where the I don't have the markings here for that, but
Yes. Okay.
so for the since I'm making a nasal incision and I'm sitting superiorly, I'll be making these. I'm using the MVR to make. Can we zoom out a little bit? So our microscope has manual controls. It does not have motorized for today. It's just gone out of. Can you zoom out? A little bit more. A little more. Zoom out. Yes, that's all. And I'll just need to recenter it. अब आप लाइट के अंदर देखते रहिए, हाँ? So I'm sorry to keep you slow, but I don't want to take any chances, and I don't have my favorite angled MVR today. So I'm using the standard. Now you have to be very careful. This is a phakic patient,
Yes.
and I don't want. So I have a straight MVR which
Right.
is being blocked by the nose.
Right.
So I'm just going to try and make a incision, and I hope I don't create a cataract. Can you give me viscoelastic? Thank you. आपको थोड़ा सा महसूस होगा, हिलिएगा नहीं, हाँ? हाँ, main port. So now we are all set
Yeah.
for the main port. And this is a 2.8, is it? Yes. And we require a 3.2 incision, so
Okay.
I'll just enlarge this a little bit. We need a 3.2 like with the other ICL, so viscoelastic. So we'll be loading the lens now.
Yes.
This is the Biotech ICL, sir.
Yeah.
It's called Acryl phakic lens from Biotech.
Right.
So the vault and all has been excellent even from day one in most of my patients.
Okay.
Can we load the lens, please?
And in terms of the sizing and everything, I mean, all other parameters, they remain the same. The way we plan for ICL or
Yeah, the white to white and sizing and
Yes,
everything
right.
is almost the
It's the
same,
same,
and they
yeah.
have their own nomogram.
Right.
So you have to provide the white to white from the calipers, from the digital calipers, and whatever instruments you have access to. So we normally provide from the Lenstar and from the Pentacam,
yes.
and also the white to white from the.
So which
calipers.
one you prefer, Dr. Gaurav? You
No.
prefer the one from the Lenstar or the digital calipers?
Sorry?
Which one you prefer, Dr. Gaurav?
So you know what I do
yeah.
actually now is
Yeah.
to rely more on my topographer, because that gives me excellent, even the new Pentacam, the Pentacam HR has a very nice option where you can actually manually measure it.
Yes.
So you should not rely upon the automated white to white which comes out of the lens star. That's usually not accurate.
Right.
So the injector, the good thing is that the injector is the same as what we normally use for our other IOLs. So I don't know if the can you show the वहाँ से आप can you show this here? आप from the camera person can आप आपसे बात करो. हाँ, यहाँ पे zoom कर सकते हैं? आप मेरे इस पे लेंस के ऊपर वो zoom कर लीजिए. हाँ, डाल दीजिए थोड़ा सा. So on the cartridge, my assistant, she is putting the viscoelastic and keeping it ready for me. कोई वो है plain forceps है? Let me see, हो जाएगा. So this comes in a vial. So the design of this ICL is pretty similar to the, let me just show you. I don't know if it will be visible, and maybe can be, I don't think this microscope is capable of zooming out, but yeah, but wo manually hoga. So this is the typical, are you able to see the ICL design?
We don't have the microscope view.
Can you switch to the microscope for a moment, please?
Yeah. Yes, now we have.
Okay, so this is the design of the ICL. As you can see, it has that small central hole exactly similar to the
V4C.
star ICL, and
Right.
in fact the design is also looks pretty similar, but now I'm going to just load it into the similar cartridge
Right.
which we normally use for our IOLs.
Sure. So how do
it
you
goes from a
yeah.
3 to 3.2 millimeter incision.
Okay, thank you, Dr.
It can go from a 2.8 there, they are telling me.
Right.
I
How
have
do
been
you-
using a 3 millimeter
Yeah.
incision. So
How do you identify the sides, Dr. Gaurav? Which one is supposed to go superiorly? Which one to go?
So the vault is quite nicely visible actually.
Yes.
So there are orientation marks here. If you look on the left, on the leading haptic, if you look, the left one
Yes.
has the small hole on it, and on the trailing haptic it is on the right side.
Right.
So that's how you can identify, and plus you can actually see the vault.
Yeah.
You know, so but as it opens up inside, you have to be careful about the marks.
Right.
So let me just load this. So I think we are all set. Let me see if the lens advances or not.
Yeah.
इसको निकालना पड़ेगा.
For the benefit of our audience, Dr. Gaurav, can you please tell what kind
can
of
blow.
viscoelastics one should be preferring in terms of phakic implants?
Can we pull this out? Hmm? Can you give me a stiffer forceps? Yeah, I think so. We'll have to do that probably. सिस्टर आप करो इसको बाहर निकालना है. एक्चुअली मेरे हाथ में विस्को इलास्टिक लगा हुआ है और सिर्फ टूट जाए प्लीज. So the lens was not advancing in the cartridge. No, it was not advancing in the cartridge. So I
Okay.
realized that.
Okay.
Let me try. The ICL seems to be coming out of that. ना? That's what. हाँ वही ना इसीलिए मैं कह रहा हूँ कि that पहले इसको बाहर निकालना पड़ेगा ना. Then we have to open the cartridge. हाँ we can break it. I think we should do that. Open a new one and a new injector. Huh? If we can get it out, go to the way. कोई artery forceps है ना तो? If you have an हाँ इससे They'll let them take out a new lens. Okay, injector. Visco. Now I will position.
Till Dr. Gaurav is.
So we are
yeah.
just loading a
Yeah.
new lens.
Yes, yes, Dr. Gaurav.
So because thankfully they had a standby, that
Yeah.
got stuck in the cartridge.
I understand. So, Dr. Gaurav, I was asking you a quick question. Like, for the benefit of our audience, can you tell them what kind of viscoelastics do you prefer in phakic implants?
Okay, so
Right.
here, I prefer to use hydroxymethyl cellulose alone
Right,
because, we don't want any IOP spikes.
right. So, one should avoid using dispersive viscoelastics.
And you have to be very, very particular about getting your viscoelastic out at the end of surgery. You don't want to leave anything. Although these lenses, this particular lens is friendly because, having the central hole,
Yes.
it does not normally. Can we zoom out the microscope, please? Yeah. Zoom it out all the way. All the way. Huh? पूरा बिल्कुल zero कर दीजिए जितना कम कर सकते हैं. So I'm just going to load this lens again because somehow for some reason it didn't advance. So
Right, right.
I'm wondering whether it was because of the haptic getting stuck in the injector
Right,
system
right.
or something, which hasn't happened to me ever.
Yeah, because these are very flexible lenses. It's easy for them to slightly slip away and get caught into the.
So I'm checking all the
cartridge,
4
yeah.
haptics now,
Yeah.
and it seems to be good.
Yeah. Good.
And
You don't want to overinflate the eye also. That's also a trick. Not to put
So as Dr. Dagar is also rightly saying that you should not also at the same time overinflate
So-
with the viscoelastics.
so now this is how the lens is already there. Now I'm just going to push it a little bit and see. And now the lens seems to be advancing in the correct way.
Yes. Yeah, we can see the lens.
Yes,
Dr.
even I
Dagar.
can now
Yeah.
appreciate it.
Yeah. Yeah.
So hopefully it'll be. Now you can just withdraw it a little bit now
Okay.
and then push it again because very rarely, if it's catching a part of the haptic, you'll be able to release that. So now it's all loaded and ready to go.
Absolutely. Great.
Can you zoom in now, please?
Yeah. Absolutely.
Yes, zoom in. Zoom in a little more. A little more. I think that's good enough. Yeah. Bas. So we are all set now to inject. Can I have more viscoelastic? And we can. I'll put some on the cornea also. So I'll put some viscoelastic on the cornea because my patient is, as it is, a little bit anxious, but she is very cooperative so far. And I'll get these bubbles out of the way.
Yeah.
Another good important thing is not to overinflate the eye with viscoelastic. Can I have that manipulator? Thank you. So we are going to go with the lens now, and I'm expecting the pupil to come down because when I started off the pupil was really small. अब आपको eyes बंद नहीं करनी है, ठीक है? दोनों eyes खुली रखनी है. So no wound assisted injection here because
Yeah.
otherwise these lenses are likely to. And as the lens opens up, you have to be careful that the mark. So can you appreciate that the mark is in the right place?
Yeah, we are seeing the lens which is showing the Mickey Mousing coming up. Yes. Yeah, wonderful, Dr. Gaurav. So now
So we
this
have
lens is above the iris plane, as we can see.
So you can probably appreciate, and you can see that the pupil did go down a little bit.
Yes.
So I'll probably have to just manipulate the lens into place a bit, and she's probably going to be a little uncomfortable.
Sure.
And as I slide one haptic under the thing, you have to be extremely careful, of course, that you don't. So I like to just, use one haptic and then the other one, and it usually just goes in nicely.
Do you always prefer to put the trailing haptic
No,
in first?
in fact, I
or-
would have done the
Right.
the leading haptic first, but because the pupil was small on that side, and I realized that my access was easier on this side,
Sure.
so I decided to change. So I'm not very rigid about how I'm going to do it, but
Right.
as you can see here, it's going to be a little more tricky on the other side.
Yeah.
The lens is catching the iris, so maybe I'll inject
Yeah.
some more viscoelastic.
Sure.
Can you give me viscoelastic, please? Thank you. So I'll go back with some more viscoelastic, and maybe my pupil will go up a little bit. Can you keep the irrigation aspiration ready? Great. So I'll try to see if now I can get my haptic in. Sometimes it can be a little tricky, but hopefully I'll manage.
Yeah.
So there goes one.
Right. Yes. Very nice, Dr. Gaurav. In
And
spite of small pupil, nice
there
tricks.
goes hopefully the other one.
Right. Wow.
So we do have the ICL now in place.
Fantastic.
I don't want to touch the optic, but I don't have a choice.
Yeah.
So with the ICL in now, I'm going to quickly do a bimanual IA.
Yes.
You have to always remember that you're dealing with a clear lens,
Yeah,
because
yes.
so I'll now wash out the viscoelastic. I'm using the upper machine, which has been proven to be excellent. So if you want to move to the other surgery, you can probably do it because the ICL is now in. If on the other side,
Right.
light को देखिए, light को देखते रहिए, हाँ.
Any coordinator in the OT who knows if the other surgery is lined up already?
If the other
we
surgery is
can-
ready, you can
right.
actually move, because the ICL is now nicely in position.
Sure,
It's well
sure.
centered.
Sure.
I'll have to just be very
Yeah.
careful about washing out all the viscoelastic.
Okay.
So can
Thank
we
you.
switch on bimanual IA,
Sure.
please?
Sure. Thank you so much, Dr. Gaurav. It was
You're
a
welcome.
wonderful
Thanks.
surgery in spite
Thank
of
you.
having so many challenges. Congratulations. Thank you so much. Thank you.
you.